I'll be moving on to the topic. The topic is about risk stratification for renal transplantation. Now, if you talk about risk stratification, this is quite important to know the immunological risk status of
Jithin, you're mute.
Yeah, you are muted, Jithin.
Sorry. The topic I'm going to discuss is about risk stratification for renal transplant. Now, as Satish sir has already said, risk stratification is very important in the assessment of a transplant recipient, especially the immunological risk assessment. This helps to tailor your
Jithin, just a minute. Can you put your slides in presentation mode? It's coming in the outline mode only.
Okay. So this helps to tailor immunosuppression as well as plan your pre and post transplant management of the patients accordingly. So just before beginning the topic, I'll just elaborate a case scenario, and which I'll deal at the end of the session. So this is a 36-year-old male who is a renal allograft recipient who had graft failure and was back on maintenance hemodialysis. His first transplant was around 10 years back, and that time mother was a donor, and there was no immediate post-transplant complication, and the graft functioned well for around 7 years. And then there was some worsening of renal function with proteinuria, and biopsy had showed a recurrence of IgA nephropathy. And now the patient was back on maintenance hemodialysis and came to me for assessment of a second transplant. And he had no related donors, and one of his friends volunteered to be a donor, whose age was 40 years. So the question is, how will you risk stratify this patient, and what would be your subsequent immunosuppressive strategy? So over the next few minutes, I will be dealing under the following this topic under the following headings. One would be the introduction, and then going ahead with the risk factors of acute rejection. How will you assess the laboratory assessment of the immunological risk, the risk stratification based on these risk factors, and once you have stratified the risk, what are the choice of induction immunosuppression, and what do the guidelines have to say, and what are the points to be considered when you choose a particular induction immunosuppressant, and successful use of basiliximab across these various risk categories, and finally summarizing the topic. So why is this important? As you all know, in any transplant setting, the scenario, the most important thing is the prolonged graft as well as patient survival. All renal transplants are allogenic, and we have got there is powerful immunological responses in the recipients, which can result in rejection, and this can lead to graft loss, morbidity, and mortality. The purpose of immunosuppression is to avoid this allograft rejection, and more potent immunosuppressive regimens can reduce all forms of rejection, but the caveat is there is increased risk of side effects. So achieving effective immunosuppression is the need of the hour, and this requires a combination of immunosuppressive agents that we use, and so that the individual side effects of these agents can be minimized. And the aim is to increase the patient as well as the graft survival following transplantation, as well as maximize the quality of life and economic benefits of transplant. This immunosuppression includes induction as well as maintenance therapy. Induction therapy has established itself as a very integral component of modern day transplantation. Now, what are the benefits and risks of induction immunosuppression? Now, if the induction therapy helps to avoid early rejection of grafts, and in cases where there is a delayed graft function, it helps to recover before the recovery of the graft and before the introduction of potentially nephrotoxic calcineurin inhibitors. You have some time when you are using this induction agent, and it also ensures a well-functioning transplant. Now, the risk associated with induction therapy is generic side effects of all immunosuppression, like increases of infection as well as malignancy in the long term, and some specific risk of particular drugs like cyclogingyl hypertrophy, cyclosporin. So there are risks associated with individual agents. Now, when you plan induction immunosuppressive therapy, it is quite essential to weigh the benefits versus the risk of therapy to the recipient. And for this, you need to know the immunological risk at the time of transplantation. And this helps to the clinician to individualize the therapy as well as avoid acute rejection without excessive immunosuppression, and also permit a more rational risk stratification of patients in various clinical trials of immunosuppressive regimens. Now let us look into the risk factors for acute rejection. Now, risk factors can be broadly classified into recipient risk factors, the donor risk factors, and transplant-related risk factors. So recipient can be immunological and non-immunological risk factors. The recipient clinical factors include younger recipient age, body mass index. The recipient immunological factors include the number of HLA mismatches, presence of donor-specific antibody, panel reactive antigen more than 0%, and blood group incompatibility. The donor risk factors include older donor age, whether there's a living or deceased donor. Transplant-related risk factors include delayed graft function and cold ischemia time of more than 24 hours. So let us look into each of these risk factors. So going on to the recipient clinical factors, as said, age of the recipient is an important factor. Younger age at the time of transplantation can increase the risk of acute rejection. Now, this has been attributed to reasons. One, in older patients, there is age-related changes in T-cell effector immune response, and in younger patients, there is a lesser adherence to the prescribed regimen, and there is increased risk of acute rejections. So this was studied by Cole et al., who demonstrated that patients aged between 18 to 24 had 1.2 times higher risk of acute rejection as compared to those over the age of 45 years. So younger age is at increased risk of acute rejection. And next is body mass index. The body mass index is usually not very significant, except in morbidly obese individuals. When the BMI is more than 35 kilogram per meter square, these individuals may be at higher risk of rejection, but otherwise weight is not an influencing factor. There's an analysis of the UNOS, which undertaken specifically to examine the effect of BMI on the outcomes, and they found that only the highest category of BMI, that is more than 35, was associated with acute rejection at 1 year compared with normal weight. And then let us look at the other risk factors which are supposed to affect the acute rejection. One is gender. Gender, there is no clear consensus, but they usually some studies have shown that higher risk of acute rejection among male recipients, while other studies have shown higher risk in females. But overall, there is no marked difference. And in ethnicity, it has been shown that black recipients have got a higher risk of acute rejection after kidney transplantation, even with current modern immunosuppressive regimens. Other clinical factors like infection, hepatitis C infection, the etiology of the kidney disease, the duration of dialysis, the presence of diabetes, especially do not seem to increase the risk of acute rejection. Now, let us look at the more important immunological risk factor. Of the immunological risk factor, HLA mismatch. HLA matching remains one of the most important techniques to identify the risk factors for kidney transplantation. Now, the degree of HLA mismatch is one of the most established risk factor for acute rejection. As the number of mismatches increases, the risk of acute rejection also increases. And while a single HLA A, B, or DR mismatch has not been found to significantly predict acute rejection, it becomes more significant as the number of HLA A, B, or DR mismatches increases. So the hazard ratio tends to increase with the degree of HLA mismatches, especially HLA DR mismatches. There is increased risk of acute rejection. Now let us look in the clinical relevance of HLA antibodies in kidney transplantation. These findings are based on prospective data, and collected from the collaborative transplant study. Now, this study found that presence of pre-transplant allo antibodies against HLA class 1 or class 2, both of them significantly increase risk of acute rejection during the first 3 months post-transplant. Presence of DSA is considered to be a modified risk factor for acute rejection as well as chronic allograft failure. And DSA is strongly associated with non-adherence to immunosuppression in kidney transplant recipients. And despite adequate desensitization protocols, the antibody-mediated rejection occurs in approximately 50% of patients with those with persistent DSA post-transplant. So a study by Mohan et al. Found that presence of DSA either class 1, class 2 or both, these are strongly associated with acute antibody-mediated rejection. Next is the panel react activity. PRA more than 0% has been widely accepted marker for acute rejection risk, even after risk after kidney transplantation. And this is uniformly included as a criteria for high risk in various clinical trials. However, the risk associated with PRA is likely to be mediated by DSA. As a result, the PRA level per se may not be very important. So those with high levels of DSA will definitely have a higher PRA level.